Right. Thank you, Matthew. So I'm Towhead, and I'm a consultant geriatrician in St George's Hospital, and I've been working for the last 2 years with NHS England and Improvement in specialised commissioning on their frailty programme, and I'm going to be taking you through frailty and also use some of the experience that I've had with NHS England to shed some more light on the subject. So in the next half an hour, I'm going to cover what frailty is, why I think it's important, and how you can go about diagnosing or measuring it, and then how to put together some initial management. So first of all, frailty is the decline in function across multiple physiological systems. And what it really refers to is this increased vulnerability to different stresses. So if you have a minor illness such as a chest infection or a cough or a cold, and you are relatively well, you will have a reduction in your function, which will quickly recover back to your functional baseline, and you will carry on with your normal day-to-day life. However, a frail older adult will have a steeper reduction in their function and then take a longer period of time to recover their function back to their baseline. And many do not recover that function, and in fact, the more severe your degree of frailty, the less likely you are to recover that level of independence. And so in the graph on the bottom line, you can see patients actually dipping from independence to dependence. And on the bottom of the slide, we have a list of terms that staff and members of the health service usually associate with the word frailty. However, what we do know is that it is a complex illness. So it is the interaction between physiology, between comorbidities, polypharmacy, sarcopenia, and the reduction in muscle mass that patient experiences. And because of this complexity, frailty in itself has been quite difficult to define in the medical literature. And because of this difficulty in coming up with a universal definition, it has made it difficult to identify at times, and also to diagnose and therefore then manage. And so when a patient presents to the hospital with their acute illness and they're seen on the acute medical take, what you see then is the acute reason for their decompensation and presentation to hospital. But the thing that remains below the surface of the water are all the other complexities to their frailty, which sometimes then become uncovered when they end up on either geriatric or non-geriatric wards in the hospital, and the layers of complexity are uncovered. And so for this reason, often patients, if they tend to re-attend the hospital and see different specialties, each one tends to deal with one specific aspect of the patient, but sometimes it does take someone to stand back and then look at the wider and the bigger picture, which is where I think the context of frailty can come in, and where myself as a geriatrician can come in by taking back and taking that wider view of a patient and thinking about where the relationships lie between the different illnesses and the different organ pathologies that a patient may have, and how it relates to their frailty. So given this complexity, how would you go about explaining it to a member of the public or to a patient themselves? So there are various different analogies that we have, and one is that of a patient who's had a reduction in their physiological reserve, or a reduction in their a bank account, for example, whereby each time there's been an acute illness, as you can see on the graph, that actually more and more is taken from that reserve, and not all of it is put back. And so actually there comes a time where there isn't enough left of that reserve, and so it results in that decompensation and lack of recovery and lack of reversibility. Also, sometimes the analogy of vulnerability and those types of terms are used. And so you can imagine that with these increased stresses that are put onto a patient, if they're particularly frail, then eventually the strength of the rope, as you can see in the picture, will start to break, and it means that a patient can become more and more susceptible to illnesses that are slowly then wearing away at their total physiological state and functional state, and so then realizes, which is then often realized in an admission to hospital where they've reached a breaking point. This example is taken from the BGS website in one of their blogs, and the analogy used here is that of a paper boat on a river, and when everything is still in terms of the water, the paper boat can sail along without any issues. However, depending on the strength of the ship and the weight of the ship, if something comes along and a wave then hits the boat, depending on the level of frailty of a patient, it may be easy to knock the boat over. You know, this idea of strength is put here, whereby if a patient has that reserve and has that is stronger, they're more able to withstand the pressures put on them. However, as a patient becomes more and more frail, they can continue for a time. However, if an insult comes to their body, that actually it may not take that much to then result in them becoming worse. So what is the patient's view of the word frailty? This is taken from an Age UK report, and which is quite detailed in itself. It is a talk in itself, but could be summed up in this statement here, that it's not something that you say about yourself, it's actually something that other people use to describe you. And actually the report found that many patients would rather talk about it in terms of their independence and their function, rather than being described as frail. And so language is one that one needs to be quite careful about when trying to have these discussions with patients and their relatives. So part of this is really the psychology of frailty. And the example that I have on the screen here is whereby a patient can go through a cascade that ultimately results in them being both physically but also psychologically frail. And so if you take a patient who's had a sore knee from their osteoarthritis, which then results in an eventual physical decline and an inability in their function, this could lead to them feeling quite low in mood and depressed, which in itself it's a vicious cycle. It leads to further physical decline and can eventually lead to frailty. Interestingly, in our current times, you could replace the term sore knee with COVID-19, and you know, us as geriatricians are worried about many of the patients that have been deconditioning at home that are starting to present to the hospital now. And you can see here that it's quite easy for a patient who's already physiologically weakened by other comorbidities to then decompensate into further frailty relatively easily. So why is this important? Well, if we look at the national population context over the next 5 years, we can see that the population is aging. That isn't a secret. However, one of the interesting things is that both men and women will spend around, on average, almost 3 years of their life with substantial care needs and increasing disability. So, for example, those living with disability will increase by about 25%. And so the healthy life expectancy of a person living in England will be up to around 64 years. And you can see there that 1 in 4 adults are currently living with 2 or more long-term conditions. So this is something that is going to be a more common presentation to us as clinicians looking after our patients. Now, in terms of the National Health Service strategy, obviously the long-term plan was published in January of 2019 and set the precedent for what the health service should be aiming for over the next 10 years. Since this was the last major development in that, I'm going to make reference to it, but obviously, given recent events, the context needs to be taken into account, and I'm sure after the pandemic proceeds and settles a bit further, that there will be further discussions about the context of the long-term plan going forwards. But when it was released, it had referred to things that make reference to frailty. So first of all, that services need to be more joined up and coordinated in their care, breaking down traditional barriers between primary and secondary care, and that the NHS will need to reduce pressure on emergency services, and in particular mandating acute frailty services 7 days a week, and there being assessment of frailty within 30 minutes of arrival in the A&E department. Importantly, also talked about person-centered care and shifting the thinking towards what matters to your patient rather than what's the matter with them. It also made reference to improving care to people with dementia and delirium, personalized care, and improving end-of-life care, but also thinking about population health management and using predictive prevention as an approach and proactivity to trying to prevent our patients with frailty to progressing further up the levels of frailty and thinking about community services. So that's the reasons why I think it's important. So then how do you actually diagnose, measure, or even screen for it? So we've talked about how frailty, the definition for it is not fully agreed in the literature. And so therefore, actually, you will also find, if you look it up, that there are multiple ways of screening for frailty. I'm only going to talk about the Rockwood Clinical Frailty Scale because I think that this is likely to be taken up as a national form of screening for frailty. And the reason for that is it's a 1 to 9 scale. It is relatively easy to use for measuring, for quickly getting an idea of someone's frailty. It can be undertaken by clinicians, but also ambulance staff, administrative staff, patients themselves, their family, and allied health professionals and nurses. And so once someone has been trained and has enough experience, which one can gain relatively quickly with this, because it is a score based on function, and taking a limited social history, that actually the score can be performed in an average of 44 seconds. And it also has a wide evidence base and has been increasingly taken up by multiple different departments, countries, specialties, and so I think it's likely to be one that we'll be seeing more and more. However, one of the issues with these types of screening tools is that there isn't one that is universally used. It's not used in hospital information systems routinely. And so it can be quite difficult to get the population overview of frailty. And so some of the work that I've been doing with NHS England has been using something called the Hospital Frailty Risk Score. There are multiple population level tools out there. This one was published in The Lancet in 2018. It is a score based on ICD-10 codes that are recorded after a patient has been discharged from hospital by hospital coders based on their notes and their discharge summary. And actually, in the original study, they showed that these particular codes, which they attached a score to, were at least twice as prevalent in the frail group than the non-frail, and actually performed similarly to existing frailty scores. So one of the advantages to this type of score is that it can be used retrospectively to look at an entire population and give you an idea of the risk of frailty. You can then relate that frailty risk to different adverse outcomes in that population to give you an idea about what's happening to them when they're admitted to the hospital. And ultimately, it allows for better resource planning for these patients. So on the screen, we've got some examples of some of the codes and points that are attached to them. These are many of the issues that I see on a ward round of my patients, and a score of 5 up to 5 is mild frailty, 5 to 15 moderate, and then 15 or more is severe frailty risk. And it's a combination of these types of codes and many others that were extrapolated from populations that were used to make up the hospital frailty risk score. As part of the application of this score with NHS England, we applied it to different specialised services, which I've listed on the bottom, which we've written into a paper which should be published in the next few weeks in Age and Aging. And what we've shown is that using this frailty score, you can show the degree to which increased length of stay, mortality, readmission rates, variation, and increased complication rates and cost of treatment can be shown across these services with frailty. And just to give you an example of what that means, if we took one of these services, what we can do is look at 1 year's worth of data and say, this is the amount of risk of frailty across that service, mild, moderate, and severe frailty. And then you can relate it to their 1 year in hospital mortality after starting that treatment, which for this specialty was 1 in 5 patients that had died within a year in hospital. And then you can look at how many days they spent in hospital during that year, which amounted to 45 days. And about a third of, this was all severely frail patients, had a risk of emergency readmission after starting their treatment as well. So then how would you be able to use this type of data? So one of the important reasons for diagnosing and looking at frailty is to then ultimately have an impact in your patient and counselling your patient and speaking to your patient and their relatives about their treatment. So say if we took an example of dialysis and you wanted to counsel them on starting hemodialysis and the commitment of having dialysis 3 times a week, you could say to them, well, if you looked at a calendar, this is what it would look like. And actually, on top of attending for dialysis, if you were at risk of severe frailty, for example, that you would spend about, on average, 1.5 months of the year as an inpatient for various problems. And also you may have a significant risk of passing away within that 1 year. This then allows both the clinician and the patient and their family to have a more informed decision when making a decision about complicated treatments such as dialysis. So that's kind of the way that you can screen for frailty at a population level, but also using something like the Rockwood scale at a local level with the patient in front of you. So once you've identified frailty using something like the Rockwood score, the main intervention would be comprehensive geriatric assessment. So this is a multidimensional interdisciplinary process whereby you manage frailty with, and it's a team sport with the MDT. The idea is that you perform a holistic assessment of your patient to come up with an integrated management plan, which is coordinated. Not every patient needs every one of the different elements. It might be that actually patient needs more therapy or more social or nursing needs, or it might be a balance between each one. However, ultimately, thing to remember is that it has a very good evidence base with a number needed to treat of only 13 to avoid a death or admission to residential care, which is, when compared to many of the other treatments that we give to our patients, is actually pretty good. So what does it mean for you, though, if you've got the patient in front of you? Well, if you were to screen them for frailty, and you found that their score was between 5 and 8, for example, mild, moderate, severe frailty, you can get an inkling as to that by taking some social history and just listening to what they're saying about the language they use when they're talking about what they're trying to deal with, what they're feeling, and how they're coping with day-to-day life. And then it will help you to have an initial thinking about what sort of things you need to think about when managing your patient. So firstly, I've got social prescribing there, which is more of the community focus for things like loneliness, which GPs have been referring to and has got a growing evidence base. And it, as you can see, is more appropriate for those that are less frail and more able. And also the same goes for comprehensive geriatric assessment, whereas the more frail your patient is and the more they are approaching a lack of reversibility, where they are more vulnerable and at risk of adverse outcomes and are becoming perhaps even to that end of their illness where they may be approaching the end of their life, then advanced care planning conversations become more of the priority, and talking about the fact that their frailty is less reversible. And so it's trying to work out when you see your patient where you think they are on this spectrum. So we know that the population is aging. We've talked about this complexity. The approach to these patients that I've just discussed, for the geriatricians that are listening, it will be something that's part and parcel of their job. However, we know that because of the national context, there won't be enough geriatricians to keep up with this demand. Nor are we actually so far have we, I think, effectively trained our medical workforce to deliver CGA to our patients when they are not cared for by a geriatrician. So many of the questions that we often hear when frail patients end up in other specialties is how to implement something like CGA when you don't have a geriatrician, or if fine, I've looked at frailty, I can score them on the Rockwood score, but then what do I do after I've done that? And this is where quality improvement methodology, I think, is something that is potentially a solution to the fact that we're not going to train enough geriatricians. And so one of the things that's been developed as part of the work with NHS England has been something called the Specialised Clinical Frailty Network. And for the specialties that I discussed earlier, but this methodology has come from the Acute Frailty Network, which was set up to improve front door frailty services. It is an improvement collaboration whereby improvement solutions have been developed, particularly in this network on identifying frailty and embedding the Rockwood Clinical Frailty Scale, and using quality improvement methodology to try and generate some of those solutions to allow teams to be given the space and the resource to try and improve identification of frailty and to try and address it in their own ways. Acknowledging that services are under strain, that we are all busy, and trying to find what's most important to your service and where you can find a way of improving. And one of the big pluses from this improvement network has been across different specialties that are all very different in their approaches to frail patients. They've all universally been able to use the Rockwood score and to embed it. And so that's something that actually, I think, by having this growing acknowledgement of frailty and being able to recognize it, that we'll all be able to then deliver better care to these patients in the future. So last year there were two documents that were published, one for the Specialised Clinical Frailty Network, but the NHS Right Care Frailty Toolkit is a general frailty toolkit which was developed and has covers all of the aspects of frailty and potential avenues of treatment, and is a rich resource. And the Specialised Clinical Frailty Toolkit also details some of the improvement methodology that I was talking about that worked for these different specialties. But does this type of thing work? So the example here on the screen is from the Royal Marsden Hospital, where a team of anaesthetists and therapists have implemented quality improvement and then frailty screening and intervention of a CGA into cancer surgery. And what you can see here on the screen is that there is a dramatic reduction in length of stay and adverse outcomes for their patients. So after the frailty program was implemented, you can see there that length of stay was halved. Morbidity and complication scores were also almost a half or a third after their intervention. And equally, readmissions rates and mortality rates went down by a half as well, with less patients being cancelled for their surgery. And this was all done without the need of a geriatrician. Now, I don't think I'd be able to deliver this talk without making some reference to COVID and the effect it's had on our frail older adults. So one thing I'll bring your attention to is this guidance that was released on how to assess patients coming into hospital with COVID-19 for escalation to critical care. And controversially, the Rockwood score was being asked to be used in all patients to assess their level of frailty before deciding whether they should be for critical care or not. Now, the thing to remember about the Rockwood score is it is a screening tool. It's not a diagnostic tool. And it's also got an evidence based in those that are age 65 and over. Whereas we know the nature of frailty in the 65 and under group is different and can be due to the underlying illness. And so actually, although the score was being asked to be done, an individual assessment of each patient was always going to be important in assessing their context to whether they should be assessed for critical care or not. And so when it comes to any treatment, it should just be in context with the assessment that you have of your patient. One shouldn't have a score and then have that as a rule in or a rule out for a treatment. One would need to just use it to give some information and then to use that score to then do a full assessment of your patient and to try and triangulate that complexity that I was talking about in terms of their frailty. And it might be that having further assessment by a therapist or other members of the MDT will help to enable that. Also, there is data that is starting to be published now about the effect of COVID-19 and frailty and Rockwood scoring. As the data comes out, we will know for sure whether actually CFS scoring had an impact and whether it predicted adverse outcomes and mortality. There was one published recently, the COAT study, which suggested that was true. So in summary, frailty is a decline in functioning across multiple physiological systems. And we've talked about that increased vulnerability and the different ways of describing it. It's associated with adverse health outcomes, increased mortality, length of stay, readmission rates, which is already established in the literature, but we've also used new tools such as the hospital frailty risk score to illustrate this across a whole population level. This is important because the population are aging, and it is part of the national strategy to address frailty because of that. However, we're not going to train enough geriatricians to be able to keep up with that demand. And so with everyone's help, including yours, by screening for frailty using something like the clinical frailty scale, we are going to be able to recognize it and therefore then signpost appropriately patients for comprehensive geriatric assessment, which has a good evidence base for helping frail older adults, or for using things like advanced care planning if appropriate. And the way to embed this type of frailty screening is by using quality improvement methodology, which you can read more about in the toolkits that I've shared, or looking at the NHS Institute for Improvement guidance on their website. And I think for anyone who's looking for a good QI project, this is one that it is relatively has a lot of information in terms of trying to embed this in the service, and it would result in high impact, I think, in the patients that would receive a CGA if it can be embedded successfully. Please log on to the website for more information, or feel free to drop me an email. And thank you for listening.